Good afternoon. Very nice to see everybody here. I'm Howie Frumkin, the Dean of our School of Public Health, and I'd like to say welcome, students, faculty, and all of our guests. This year's Gloyd Lecturer and winner of the Distinguished Alumni Award is Dr. Mary Travis Bassett, Commissioner of the New York City Department of Health and Mental Hygiene. Dr. Bassett completed her undergraduate work at Radcliffe, her medical school at Columbia, and internal medicine residency at Harlem Hospital, where she was chief resident. Upon completing her MPH here at UW, she headed for Harare, Zimbabwe, where she served on the medical faculty at the University of Zimbabwe for 17 years. In that role, she developed a range of AIDS prevention interventions to address one of the world's worst AIDS epidemics. She later served as Associate Director of Health Equity at the Rockefeller Foundation's Southern Africa office and at the Doris Duke Charitable Foundation, leading the African Health Initiative and Child Well-Being Program. Throughout this work, she was focused on strengthening systems to support health improvement. In January 2014, Mayor de Blasio appointed Dr. Bassett Commissioner of the Department of Health and Mental Hygiene, the largest of our nation's 2,800 local health departments, with about 5,000 employees and an annual budget of roughly $1.4 billion. Her work with the department dates back to 2002, so she was no newcomer. She was appointed back then Deputy Commissioner of Health Promotion and Disease Prevention. She directed key initiatives, including bans on smoking and trans fats in restaurants. She also established the department's district public health offices in East and Central Harlem, South Bronx, and North and Central Brooklyn, communities that experience an excess burden of disease. Each office advances community health through home visit programs, free exercise programs, increasing access to healthy food, and coordination with local coalitions and doctors.
It's very special to me to introduce Mary. I've introduced Gloyd lectures for a couple of times before, but none have been quite like Mary Bassett, because Mary is a personal friend and someone whose career trajectory has overlapped with mine for literally 40 years, more than 30. I met her for the first time when she came here as a Robert Wood Johnson scholar. We're still arguing about exactly what date that was, but I was kind of a newly minted faculty member, freshly arrived from Mozambique, and we shared a common commitment of anti-apartheid activism. In the late 80s, after Mary went to Zimbabwe, to the University of Zimbabwe, I ended up following her, and I did a mini sabbatical there for a couple of months, for 3 months. And I remember that during that period of time, it was really clear what Mary was doing. She had already become well known as a leader in the struggle for equity and health in Africa, also fighting for the right for universal AIDS treatment, and for ending the crippling austerity programs that most African countries were facing during that period of time. And I remember she gave an impassioned plenary speech at one of the early International AIDS Society conferences that turned many heads, I would say. She rarely minces her words, and her work has always been guided by her values and social justice, and I think that was a really important speech at that time. When she came back to New York City, she worked with the Doris Duke Charitable Foundation, and that gave all of us at Health Alliance International a chance to work with her as a donor, which was an interesting relationship. And she was like few donors I've ever known, where she listened with humility, with grace, and I shouldn't say this with other donors in the room here. But she worked hand in hand with us, almost as a team member, as much as a team member than a grantor, to address some of the intractable issues that we both recognized, that we all recognized, and it was a really amazing relationship that we had. Mary, I would say, is just simply an amazing person. She's a longtime activist, she's a visionary, she's a leader, she's a wonderful, sweet, and caring person. And in fact, one of my students told me today, after hearing what she said in a seminar with students, she's just so cool. I'm very honored to be her friend. Mary, thanks.
Is it up there? I've chosen as my topic a subject that has guided my entire working life and my entire adult life, actually beginning in my adolescence. So I have a lot to say. So I just want to warn you all in advance that I'm going to be talking for probably about an hour. And I hope I can keep you interested and entertained for that time. My title, Public Health as Social Justice, Lessons from Harlem to Harare, borrows from an article that was written almost 4 decades ago in 1976 by Dan Beauchamp, who was then an assistant professor at the School of Public Health at the University of North Carolina. And he wrote in an article titled Public Health as Social Justice, while many forces influence, and I quote, the development of public health, the historic dream of public health that preventable death and disability ought to be minimized is the dream of social justice. Yet these egalitarian and social justice implications of the public health vision are either not widely recognized or are conveniently ignored. In A Vision of Social Justice as the Foundation of Public Health, published in 1998 by Nancy Krieger, who's also a fellow alum and a close personal friend, along with Anne Emanuel, who I understand spoke in 2012 as a Gloyd lecturer, they provide a historical reflection on the formative years of public health and the, quote, movements around the world champion social justice and the political and economic democracy. So we should all be remembered that this is the key legacy of our profession and our field. And they also, and I quote again, caution us to remember that the field of public health, in fact, has many strands, repressive as well as progressive. And recognizing these conflicting legacies can illuminate contemporary debates about public health research and action, and also help uncover ideologies and policies that contribute to or even expand social inequalities in health. So my talk to you today is informed by the writing and thinking of numerous scholars of present and the past, including faculty and alum of this school who've committed their working lives to pursuing public health as social justice. And I'm also going to draw heavily on my personal experience working and living in Zimbabwe as well as in New York City. And I want to begin by returning briefly to the Declaration of Alma-Ata, signed in September 1978, at a time that many of us, of my age at least, were in the formative years of our careers. This international document on primary health care is really still considered groundbreaking, and it continues to guide my work in that it acknowledged explicitly the importance of bridging primary health care and public health, and also the foundational role of social justice and advancing the well-being of populations. But, and I'm sure this is not true today, I have to tell you a vignette, because when I went to Zimbabwe in 1985, every meeting that I attended with my colleagues at the University of Zimbabwe, people were talking about Alma-Ata, and I didn't know what Alma-Ata was. Well, I confess, I was totally smitten by epidemiology when I was here, and I spent a lot of my classwork on that. And I'm sure that graduate students today don't leave as ignorant as I was. But I went to the basement of the library, dug up the original document, and I think it's worth reading the words also quoted on this slide as I read them back then in 1985, because they still hold true today. The existing gross inequality in the health status of the people, particularly between developed and developing countries, as well as within countries, is politically, socially, and economically unacceptable, and is therefore of common concern to all nations. The Declaration also provides a very comprehensive definition of what is meant by primary health care, stressing that it includes a whole range of actions from education to access to safe water and sanitation, to prevention and care, and a number of sectors, not just the health sector acting alone. If you haven't read the Alma-Ata Declaration, I urge you to do so, because although we have failed to meet its ambitious and aspirational goal, the attainment by all peoples of the world by the year 2000 of a level of health that will permit them to lead socially and economically productive lives, we have much to regain by reminding world governments that they made this declaration a commitment over 3 decades ago. And I think many of us around the world would agree that the values and commitments outlined in the declaration and the approach called for in coordination across sectors were the right ones. So, what went wrong? Sadly, the rise of thinking about primary health care and the conviction that, quote, governments have the responsibility for the health of their people, which can be fulfilled only by the provision of adequate health and social measures, coincided with a global debt crisis and a shift to conservative macroeconomic policies. Most strikingly, the imposition of structural adjustment policies undermined the very ability of governments to meet their obligations as set out in the Alma-Ata Declaration. Introduced by the IMF and the World Bank in the 1980s, structural adjustment policies focused on, quote, export-driven development, where countries devalued their currency, limited labor protections, and reduced barriers to foreign investment. By limiting the size of government, including requiring cuts in social sectors and reductions in the size of the civil service, something that everyone working in public health in Africa remembers in a visceral way, the consequences included higher prices for basic goods, lower wages, social spending cutback, just to name a few, were the opposite of what was needed to address the social determinants and the challenge of social justice, which were fundamental approaches to public health. So while concerns were raised about the social impact of adjustment policies, including in the late 1980s by non-governmental organizations as well as international organizations like UNICEF that published Adjustment with a Human Face, the late 1980s saw health sector reform initiated based on market principles and no longer a set of common values. So this led to a return in vertical programming, to fragmentation, and the erosion of community health structures. In many countries implementing structural adjustment policies, there were reported increases in infant and maternal mortality and other negative health outcomes. So I'm going to return to this topic when I provide some of my personal reflections about my time in Zimbabwe, a country which adopted structural adjustment program in late 1990, motivated at that time for a badly needed global investment and increase in capital. It's also important to highlight that since 1990, there was a rapid expansion in global health funding, doubling between 1990 and 2001, and doubling again by 2007, which is the date of this slide. It's probably been updated since then. While additional funding for global health was indeed most welcome, it's important to step back and think what this meant, what it meant for private philanthropies and or the U.S. government, or charitable organizations such as the one for which I worked, or international organizations, to control the resources and by extension the decision-making by countries on what should be funded, what the policies and priorities would be, and what the solutions were to which they should direct funding. And this obviously is a whole topic in itself, but I just wanted to quickly point out the potential for proliferation of actors and the shift in dynamics due to an influx of many more resources that further undermined the role of governments in the developing world and created systems where governments were increasingly accountable to donors and not to their own people. Well, the question, is there anything to be optimistic about? Might we be at a turning point where the principles of alma ata and where public health's commitment to social justice can be reaffirmed? Well, in October of 2011, world leaders met in Brazil and reaffirmed, and if you recognize this language, I know that you have been paying attention, that quote, "Health inequities within and between countries are politically, socially, and economically unacceptable, as well as unfair and largely avoidable. And the promotion of health equity is essential to sustainable development and to a better quality of life and well-being for all, which in turn can contribute to peace and security." But it is concerning to me that while there's much more widespread talk of the social determinants of health, there's much less talk about the political determinants of the social determinants. And the term social justice is conspicuously absent from the political declaration of the World Conference on Social Determinants of Health, even though it was included in the Alma Ata Declaration. So we're also seeing a revival of the concept of health in all policies, which, as some of you may know, is the topic of the upcoming American Public Health Association annual meeting. And this is a positive time. This is a positive sign. But I think I should ask the question if perhaps we should be talking about equity in all policies. And finally, I want to acknowledge that there is a code of conduct for NGOs, the Health Alliance International, and Steve Gloyd in particular have been very involved in this. And this is a part of a growing effort to ensure that efforts to strengthen health systems in poor countries don't compete with and undermine government. So I'm going to turn now, having sort of set this broad stage on a global level, on the issues that I think led to a derailment in public health, its intended social justice agenda over the last 3 or 4 decades, shifting instead to a much more biomedical and technical approach to health. And now I'm going to talk a little bit more personally about how I experience these global trends and working in different settings, from Harlem to Harare and back again. So the rest of my talk is organized in 2 parts. I'm going to talk about my personal experiences in different settings to describe the practical opportunities as well as the changes and obstacles to using public health practice for advancing social justice. And then I'm going to turn and consider how academic departments can work in partnership with health departments and how students and researchers can help inform the solutions that we implement as practitioners. So while I was asked to talk about global health, the key message of my talk is that making injustice visible and acting on it is important for all of us, whether we are working in an urban center in the United States or a rural community in Latin America or an urban slum in Africa. Tackling injustice in the US as part of the global health movement for greater equality and equity is political, as is this type of work anywhere. But let's not shy away from it. So let me turn now to my personal story and talk a little bit about how I chose to go into medicine. After graduating from high school, I worked as a census taker in 1970. It was a census year. And in those days, census takers went door to door, knocking on doors with a satchel. And I talked to people witnessing their health problems in their homes. And I decided to become a doctor. As far as I know, I'm the first doctor in my family. So then I went on to college, and you can see me as a college student pictured there on the bottom at a Black Panther free health clinic, part of a proliferation of community free health clinics, where I worked in college as well as getting this clinic staffed asking all sorts of people I learned later were quite well-known academics to volunteer as primary care doctors in this clinic. I also got a whole screening program going for sickle cell anemia screening in Boston's housing projects. And from there, I went on to go to medical school and then chose residency at Harlem Hospital. And I've shown this graph because I wanted to remind you all what it was like in Harlem in the 1980s. This is a really iconic graph that compared the chances that a man in central Harlem, based on 1980 census data, would survive to the age of 65 as compared to a man in Bangladesh. And as you can see, the odds of surviving to 65 were lower for a man in central Harlem than they were for a man in Bangladesh, than one of the nation's poorest countries. And the only reason that black women in central Harlem did better than Bangladeshi women was because of the truly, astoundingly terrible odds for Bangladeshi women. And this analysis was done by a surgeon. I believe we have at least one surgeon in the room, Coke McCord, who actually continues today. He's an advisor of mine at the health department. And Dr. Gloyd will remember him because he worked for many years in Mozambique. From there, I came to Seattle, and that's me working, I have so many memories from my time in Seattle, and I worked as a Robert Wood Johnson clinical scholar. It was a truly idyllic time when we had resources, both human, meaning intellectual, and material, meaning access to libraries and resources to do research. And after I got over the shock of moving from central Harlem to gray Seattle, I have to confess that I remember it as one of the truly rich time for me in development. You'll see me there with Nancy Krieger, who is known to many of you, graduated from here. And there's Steve. Since I'm showing myself as a youngster, I thought I'd show you as a youngster. There you are in Mozambique. That's Paul Epstein there. So it's not surprising to me that many alumni from this institution went on to pursue careers that were really molded by the goal of social justice, and also to pursue working lives in the international arena, even though I had been up to that time completely domestic in my focus. In 1985, I moved to Zimbabwe, a country in which I spent nearly 2 decades and learned many lessons that I brought back to my work in New York. And here you see 2 pictures of me, one from my early years in Zimbabwe in 1987, and then one shortly before I returned to the United States. I worked as a faculty member at the University of Zimbabwe. And what I'm going to describe in the next couple of slides is the dramatic transformation that occurred in Zimbabwe while I was there, from an early post-independence economic boom and the climate of optimism and excitement that existed there, when there was a real commitment to progressive health policy, to a situation where the failure of structural adjustment policies led to uncontrolled inflation, food riots, political uncertainty, along with the impact of one of the worst AIDS epidemic in the world, all these combining to lead to sharp reversals in health. Social justice was very much at the core of Zimbabwe's health policies in the 1980s. And the new government, emerging from a long war of independence, immediately announced a socialist agenda. And the main outcome of this was greatly boosted investment in healthcare services and in primary education, which became essentially free at independence. There was a massive expansion in rural health centers with a goal that all the population be placed within 2 hours walk of a health service. Roughly 80% of the population was covered in the 1980s. But as these graphs show, there were later dramatic reversals, and these are data from the World Bank, in life expectancy, which fell from a high of 61 in 1985 to a low of 42 years in 2003. And contributing to this were both the decline in the healthcare sector and the ravages of the AIDS epidemic. Infant mortality rates rose, and deaths of children under 5 rose. Zimbabwe now has a maternal mortality rate of about 700 or 800. So why did this happen? Well, by the 1990s, everybody agreed that however structural adjustment was intended to work, that it was failing. Of course, they didn't agree on who was to blame for this failure. The World Bank blamed the government blamed the strategy, but while real per capita expenditure did not change dramatically between 1980 and 1998 in the healthcare sector, the health impacts of adjustment were very broad. And a big part of my research during these years was looking at the impacts of adjustment, something that I undertook with David Saunders and others. We showed many effects of the adjustment program. Zimbabwe was particularly ill prepared to deal with its AIDS epidemic. These are data that reflect just numbers of deaths in Harare adults during the period of between the mid-1980s until the late 1990s. And you can just see the incredible increase in adult mortality, as well as the real divide between the African community, which was experiencing this elevation in mortality, and the European population, which was virtually untouched by the AIDS epidemic. When I think back to the Zimbabwean AIDS epidemic, and I think of our response, because a great deal of my own work was focused on HIV, we certainly did not react with enough alarm to this unfolding tragedy. So while my colleagues and I talked about structural causes, we talked about male migrant labor, gender inequality, military mobilization, all things that I talked about at the AIDS conference that Steve mentioned as we got started, and we handed out condoms, the epidemic spread much faster than any of our efforts to address it. So framing the public health response to AIDS as a social justice response forces us to ask a number of questions about responsibility and accountability, and the role of government in response to the AIDS epidemic, the non-governmental organizations, the pharmaceutical companies, all of us together really have to reflect on how we responded to this epidemic. I did all sorts of work beyond talking about the structural drivers. I worked with sex workers. I established programs aimed at teaching girls, empowering girls to defend their right to insist that their male partners use condoms. When I think back on this, some of it seems a little bit like teaching hand washing in the midst of a cholera epidemic. It was not wrong, but it was misguided. We really should have insisted that there be a far more aggressive response to this escalating rate of infection in the population. In some settings, 60% of women seeking pregnancy care were found to be HIV infected. So this was really not addressed until the combined effect of growing economic lockdown, which deprived the population of movement and of any kind of sort of extracurricular expenditure. Husbands were, in fact, committed to their families and decreased their number of partners, and We saw a decline in HIV incidence as well as an improvement in HIV treatment. Those dark blue, they look black to you, bars reflect the contribution of HIV. So you can see between 2000 and 2012, the efforts to treat HIV really had a substantial impact, as well as the declining incidence. So in spite of many, many things going wrong, the response to AIDS eventually did catch up, even though everything else remained virtually the same. And we have seen a recovery of life expectancy in Zimbabwe, still, though, not up to the level that it was before the advent of the AIDS epidemic and the impact of the structural adjustment program. So in 2000, in 2002, I left Zimbabwe and returned to New York City to serve as a deputy commissioner. And as you know, for a little bit over a year now, I've been lucky enough to serve as the health commissioner for the New York City Health Department. I left Zimbabwe as it really plunged into an ongoing period of economic and political instability, and returned to New York to really taking many of the lessons with me from Zimbabwe to my work there. And in the next couple of slides, I'm going to talk about how the work I did in Zimbabwe would affect my work in New York City. And there are two fundamental lessons that I took from my work in Zimbabwe and which I am continuing to use in my work as health commissioner. One is that when communities are actively engaged in the pursuit of their own health, we are more successful in public health. And the other is that government action is also needed, primarily through policy, to ensure that healthy choices are the easy choices. I refer to the first as a bottom-up strategy, the engagement with communities, and the second as a top-down strategy, the responsibility of government to create a healthy policy environment. So when equity is the lens through which we plan and evaluate success, then a strategy which couples bottom-up with top-down, I believe, is the best strategy to advance social justice. So one of the key lessons that I brought back from Zimbabwe was that district health models work. And in Zimbabwe, a key concern and motivation for rural health clinics was to ensure closer proximity of services. Reducing distance is not the only reason to implement such a model. It also is to better target and tailor services so that they are better advanced through a decentralized model. So just as trickle-down has been debunked in economics, I think similarly in public health, we can't assume that improvements in overall health due to new medicines or new technologies or even new policies will lead to improvements in everyone's health. And being close to the ground is really important. So mindful of this, when I returned to New York, I set up 3 district public health offices in locations with the greatest need, namely the South Bronx, East and Central Harlem, and Central Brooklyn. Of course, this is not a new idea in New York City. Almost a century ago, the department began a neighborhood health center movement, first in 1921 through a demonstration project in East Harlem. And as described in the 10-year report of the East Harlem Health Center, the founders of the East Harlem Health Center were of the belief that peoples and agencies would cooperate when cooperation was made practicable and not too difficult of accomplishment. This is, I'm quoting from the report then. They felt that propinquity would breed acquaintance, cooperation, and teamwork has brought the power to increase efficiency and to prevent duplication of effort and to discover gaps in local health programs and to provide service needed. time has proven that the founders were right. Over a 10-year period, they were able to change the mortality curve in these communities. And based on the success of the department in 1929, committed to the establishment in each of the 30 health districts of a district health center that would serve about 200,000 residents. So in New York City, we are committed over the next few years to opening 8 neighborhood health hubs. 2 will be opened by the end of this year. And specifically, we will provide a physical space for co-location of different services, including with a goal of bridging public health and primary care. And we are intending to bring back into these health hubs medical and health services. And my aim is to use a social determinants of health approach and bringing a much broader set of actors to the table. This is going to include artists, activists, different actors in different sectors like transportation, housing, the Parks Department, and represent the diversity of each of these neighborhoods. So I'm hoping that some of these health hubs will have a communal health kitchen, a communal kitchen. Some of them will have urban gardens when they have the space. And we're going to have some with rooms for new moms to come together, for breastfeeding support, and even include space for young entrepreneurs to explore cool ideas. I hope we'll have some cool ideas in these health centers. So the types of activities that I see coming out of these district health centers is very broad, but it could include engaging directly with residents and as community health workers. So one of the things that we've recently begun is in our East Harlem District Public Health Office is a community health worker initiative working with community-based organizations, and we, as well as the community-based organizations, have identified and launched the community health workers. We're working with various academic institutions to both to oversee the training and evaluate this pilot, and of course this builds on the success of community health workers from around the world. And in addition, we are focusing in particular on chronic conditions. That hotspotting graph that you see there is of hemoglobin A1Cs that show them the red is for people with hemoglobin A. This is a measure of uncontrolled diabetes. And those are areas in housing developments. We've made this a reportable test. So we get all hemoglobin A1Cs that have been taken on people resident in New York City since 2006 are reported to the health department. And so we're able to identify these housing developments and the hot spots of uncontrolled diabetes. And that's really going to be a focus of our community health worker initiative. We have 14 of them working in the field. They've recruited now about 75 patients. They just started 6 weeks ago. So I'm very hopeful that this will be an effective strategy. So while this is really focused on the management and of improving disease outcome, it's a biomedical model because we want to ensure that people are linked to care, remain in care. We also want to support individual behavior change by using building-based approaches and smoking cessation, walking clubs, teaching people how to shop in area supermarkets and read labels. And so we're aiming for a much broader model than simply finding and treating people with diabetes. So that brings me to the notion of how we complement a bottom-up strategy with a top-down strategy, because health departments clearly have a critical role to play in improving the environments in which people live and removing structural barriers to health. And our tools for this, our policy tools, include regulation, legislation, taxation. And when I returned to the Health Department in 2002, my primary focus at that time was on the food environment. And you probably have heard of our efforts to eliminate trans fat from restaurant food, also to implement calorie posting. Both of these are now being addressed at the federal level. Calorie posting is part of the Affordable Care Act, and it will become national soon. And the FDA is now hearing evidence about the removal of trans fat from our food supply, which is, of course, the most important and effective way. It was successfully done in Denmark. They know a lot about fatty food. I think that I should point out that the Health Department has a real asset in leading these sorts of policy changes in its Board of Health, which has regulatory authority, the power of law, controlled by the Board of Health. The Board of Health sought to extend its authority to sugary drinks, and in this we had a very public defeat, I would say. But I want to point out to you all that even when things fail, it doesn't mean that they were not the appropriate public health strategy. And it is important for me to highlight it again because we're still focusing on it. Sugary drinks, as these slides show, are an important source of added sugars in our diet. They account for half the added sugars in our diet. Soft drinks sugary drinks include not only soda, although that's a simple way to talk about it, includes sports drinks, fruit drinks. The World Health Organization, congratulations to them, had made it to a recommendation that 10% or less of calories should come from added sugar. So we are nowhere near that in the United States, although this was recently echoed in the scientific report of the 2015 dietary guidelines. And of course, we know that the reason that we drink so much sugar is not only that people like these, but they have been successfully marketed to us. The industry targets children. Over $400 million a year is spent directly marketing sugary drinks to children. And in 2013, Black youth saw more than twice as many ads as white youth for sugary drinks. 2013, Hispanic youth were nearly twice as likely to visit a website of a beverage company. And there's been a real escalation of advertising for sugary drinks on Spanish language TV. It went up by nearly 50% from 2010 to 2013. So ambitious public health policies can improve the food environment, make it easier for everyone to live healthier. There's extensive literature to back the need for a public health approach to sugary drinks, and I just want to assure you that we haven't given up. Something else, of course, that New York has pioneered in is tobacco control. And you can see from this slide that after many years, you can't see this here, in 2002, that 21.5% had been flat for many years in New York City. But beginning with a whole host of aggressive policies, the smoking rate has gone down, but we recently saw an uptick at 16.1%, as which our most recent estimate is statistically higher than 14%. We now have more than 1 million smokers in New York. And our latest data show that smoking continues to be socially patterned, with smoking rates lower in adults with a college degree compared to those without, and it increases with lower income. And importantly, it's twice as high among adults with serious psychological distress. That's the gray bars there, than it is with people without. So quitting smoking may require changing the conditions that people live in and reducing stress. So now I'm going to turn to academic departments and the ways in which students, researchers can partner with health departments to address health disparities and advance social justice. So I'm going to talk in three broad areas. One is to help us better design interventions and policies by developing theoretical frameworks and methods that get at the structural determinants of health, helping us map inequality, because mapping is such an effective way of making visible injustice, and also of helping guide our targeting of resources. And third, helping us to better understand the dynamic relationships between the local and the global, and how action at one level can impact another. So I'm going to touch briefly on these. I'll go quickly through this one because these are these are sort of dense, this is a dense slide, but you might find it surprising that a public health practitioner, which is how I would describe myself now, would highlight the importance of theory. But I want to do that because it's so important that we have a theoretical framework which enables us to ask the right questions. And the policy implications of our theories really can't be underestimated. So here I have shown on the left, for you, the left side of the slide, what's most commonly used as a model for how we consider the relationship between the individual and the community in terms of health effects. This is a model that's been embraced by the CDC. It appears on their website. And then I have the model that Nancy Krieger has promoted, known as the eco-social model. And a key distinction between these two models is that the determinants of population health are not the same as models of the determinants of health inequities. This is really important. The social ecological model, that's those concentric circles, is a very useful model of social determinants of health, but it says very little about the inequities in the distribution of power and resources or time and place. And even in a completely equitable society, the social determinants of health would be important for public health to consider. But when disparities are as stark as they are in New York City, where our neighborhood with the lowest life expectancy has an 11-year gap with our neighborhood with the highest life expectancy, then I would argue that we must begin to discuss explicitly class inequality, racial and ethnic inequality, gender inequality, as Dr. Krieger's model does. And I also find misleading about this social ecological model, the concentric circles, that places the individual at the center, is the fact that it creates this visual distance between the outer circles, such as policy, and the individual. And it implies that action at the individual level is more immediate and makes a bigger difference than action at the policy level, which is in fact not true. Policy is very personal. It affects people every day. And this image gives the sense that it's far removed from individual impact. So these sorts of discussions, I think, are very helpful to us as practitioners, and I want to urge people in the academic arena to help us who work at the interface of public health and policy by creating models that include the notion of what drives health inequities and make more explicit power and accountability. That helps us design better interventions. And it's also important to think about how neighborhoods function. We're all thinking much more about neighborhoods, whether it's in a district in a developing country or what we think of as an urban neighborhood. And this kind of work has grown in the domestic arena really exponentially over the last decade. And of course, I don't have time to talk about this either, but I think it's important to really tease out the ways in which a neighborhood can affect, independent of the individual, which of course individuals are important, and what they do and the choices they make are important. But there are things that are above the individual level, things like residential segregation, which is highlighted in Anna Diaz-Rue's model, which I show you here, which we should also consider as a determinant of health, and which is obviously not an individual behavior. Similarly, the built environment in a neighborhood is a characteristic which has no equivalent at the individual level. Now, let me turn to talking about how we can make injustice visible by using graphic tools like mapping. And these have two really complementary roles. One is anyone who sees these, I think, finds that, and anyone who uses them finds that they're really much more effective in generating outrage and the political will for change. And they also help us target our interventions appropriately to the places that have the highest need. And maps work in many, to distinguish needs at both the global, national, and local level. So I'm going to show you a couple of examples. Probably you're all familiar with these. This is a map which shows very clearly the difference in healthy life expectancy and the importance of focusing our efforts as global citizens on sub-Saharan Africa, which has the lowest rates of healthy life expectancy, which is what we all want. I think it's easy to agree that no one wants to live, and not be healthy. Nobody's interested in just living a long life without those long years being ones that are healthy. So this is a difficult measure to capture, but one which is an important measure to everyone, and it really makes clear the way in which sub-Saharan Africa is falling behind. And you probably are all familiar with World Mapper, which makes swells and shrinks according to the prevalence of different conditions, which similarly makes very clear the burden and much more graphically than other types of representations. This is another really interesting idea that has been pioneered by the Robert Wood Johnson Foundation, which uses the connections of our cities by roads or public transport to show how side by side we have huge variations in a common measure like life expectancy. So the map on the left shows the disparities in life expectancy ranging from 77 to 84 years, just along a metro ride away on the DC Metro. And the one on the right is New Orleans. It's even a starker picture with a gap of 25 years in life expectancy, less than a few miles apart. Here we have different ways of showing the obesity epidemic using the World Mapper notion, showing where we should, well, look at, you should be proud. You all shrank. And I always enjoy, and I'm going to flip through for you, although I promise you it won't take very long, these maps that are done on obesity trends in adults from the CDC. You can do them sort of like flashcards, and here we go. As you change colors and colors get darker, things are getting much worse. Have you all seen this before? Well, I'm just going to go. This is 86, 87. I tell you, you wonder that the continent hasn't sunk. So this is 30%, that dark red, 30% of adults are obese or overweight. Actually, that's just, that's really pretty, that's just plain obesity, actually. That 30% of adults are obese. And here's a map that I show often in New York City because it shows, I don't know whether you can make it out, but these are all different, different conditions. Asthma, hospitalizations, HIV deaths, the diabetes deaths, and hospitalizations for drug overdose. And these are not only show that the same neighborhoods show up again and again as the neighborhoods that are struggling with high disease burdens, but that it doesn't matter what the causal pathways are. Diabetes is very different than asthma, obviously, very different than HIV, but nonetheless the same communities, poor communities in New York City, that means communities of color, systematically light up. So this clustering shows that irrespective of the causal pathways, whether we're talking about infectious diseases or non-communicable diseases, so it really makes it clear that larger structural factors are at play. And having maps then really makes injustice visible. And I think in partnership, we really have the obligation to ask the question, why is this so? We need to explain these maps. And it was in part to ignite that conversation that I published just this past March in the New England Journal, a piece to encourage critical dialogue and action around racism and health for health professionals to engage with the larger social movement that has been emerging across the United States under the banner Black Lives Matter. And this, and I met with students from the New York City area medical schools. They all were part of a movement called White Coats for Black Lives that in fact began on the West Coast. I expect that it involved your students here at the University of Washington. They held white coat die-ins, and I am continuing to dialogue with deans at the different institutions around New York City and these students to think about ways we can transform our own practices. It's been a real goal for me at the health department to diversify my particularly our public health programmatic staff. I depend on institutions of higher learning, particularly medical schools and schools of public health, to provide the pipeline for that hiring and recruitment process. So the issue of ongoing and exclusion and discrimination against people of African descent across the life course, along with a whole host of bad policies that have been part of the history of this country, really continue to shape the pattern of disease, the nature of our workforce, and I think we really must be brave and talk about the issue of racism in our work. So this leads me to the third area where partnerships between academic institutions and departments of health can be useful and help us initiate successful efforts in different places. So while global health is often framed in a unidirectional way, with knowledge flowing from the wealthy north to the developing world, I've really tried to highlight how practices that I gained with my own personal experience, how practices and experience I had in Zimbabwe influenced my work in New York City. I talked about the Community Health Workers Initiative, and I talked about our focus on neighborhoods and the idea of district health centers, and we also can learn from different policy initiatives which have been emerging in the developing world. New York City had a not so successful experience with conditional cash transfers, but I think this remains an interesting experience. And it's really important also to think about how we're interconnected. For example, I talked about our decline in successful, and I think an area that we have already measured and shown is contributing to the increasing life expectancy in New York City, efforts in tobacco control. So it's important, though, to remember that in absolute terms, the number of smokers are increasing around the globe. And sometimes our success in public health in our nation is exported as failures in public health elsewhere. So we must keep in mind the disparities within countries and not be too, between countries, and not be too narrowly focused on our own setting. And we need to step back always and take a look at the global picture before we congratulate ourselves too much on our successes in chronic disease. This is also happening with the food industry, which is at a galloping pace, taking hold even in Africa. So this tension between a local success and a global disaster really became clear to me in recent months when New York City became part of the larger global Ebola conversation. Ebola was really my first public health challenge as health commissioner. It's what brought me and New York City's health department into a media spotlight. And I think everyone would agree that New York City was successful in its response to Ebola. We turned the page on Texas. Craig Spencer was cured. No one else got infected. But I was very conscious of two things. One, that our work in New York City was not contributing to ending the epidemic in West Africa. We were really just focused on the protection of our own population. And I was also very concerned at the time that our West African community might be stigmatized further. So with this in mind, I made really conscious efforts to engage with West African community members and deliver facts to them, facts that were useful to them and to their families back home. But undoubtedly, from a social justice perspective, the success in New York really doesn't mean anything unless we continue to talk about the over 10,000 individuals who've died in West Africa. The medical and public health communities have to consider the reasons behind this failure. It undoubtedly, although I am a big supporter of the World Health Organization, I think we have to acknowledge that WHO had failures. The public health emergency declared in August was too late, and it was ineffective initially, maybe, and I would argue certainly this had something to do with a 50% decline in their budget to enable them to respond to outbreaks. And of course, we have to remember how weak the health systems in many African countries have been left. It's not just a natural phenomenon for African health systems to be weak. They didn't become weak by accident. There's a whole history related to colonial occupation, health worker migration, the structural and historical issues that I've highlighted today. And of course, we have the Ebola epidemic uncover the unseemly and unacknowledged phenomenon of urbanization in Africa, which has left huge swaths of the population in need of 19th century public health, meaning sanitation, water. This was really an epidemic of the urban slums. And I just needed to end, not on this sad note, but to add one more slide in my many slides to remind you that even as we talk about the many challenges that face us and how challenging it is to address health disparities, we also have to remember that public health is fun and that for all of us committed to social justice, that there's a lot of fun in the work that we do. This is a picture of me with my senior leadership. This is the same team that led the Ebola response. You can see us there at the World AIDS Day Red Ball at a disco. That's me in my condom crown. And we were celebrating with our community partners and activists the success of the AIDS response in recent years, and having fun, laughing, dancing, and rededicating ourselves to our work. That is also part of public health. And I thank you for your attention, and I'm happy if we have any more time to answer some questions.